Hello and welcome to Fun with Pharmacology. Today we'll talk about CHF, that is congestive heart failure. We'll begin by discussing what is CHF. Importantly, what's the difference between heart failure and heart attack. Then we'll go on to see what can lead to development of CHF, what are the presenting symptoms, and if we do not take care of this patient, what will he land into? So what is the forward adverse prognosis of living with congestive heart failure? After that, we'll see the pathophysiology of congestive heart failure. That is, what is going wrong? What is the deviation from physiology which manifests as congestive heart failure? And thereby try to understand which are the key drugs in management of congestive heart failure, both as chronic management and management of the acute situation, that is acute LVF. So let's start with the beginning. What is congestive heart failure and how does it differ? How does heart failure differ from heart attack? Heart attack is an acute episode, whereas heart failure, it's a chronic developing situation where there is reduced force of contraction. As against this, as I just said, heart attack is an acute episode where there is sudden obstruction in the blood supply to the myocardium, resulting in infarction, that is tissue death of part of the myocardium. So this is a major distinction. Heart attack is an acute episode where the patient necessarily should be into the ICU care as early as possible, whereas congestive heart failure patients can be ambulatory within their capacity, but they can be ambulatory going about their daily routine within their capacity, and if they overexert, they may need acute management. So what is basically wrong in congestive heart failure is reduced force of contraction. And how do we assess the severity of congestive heart failure? It is assessed by measuring the ejection fraction. So what is this ejection fraction? Out of the blood which has come back to the heart, how much is getting pumped out? This ratio is called the ejection fraction, and if that gets compromised too much, the patient may require acute treatment. Otherwise, many of these patients are ambulatory. What can cause the patient to go into heart failure, or what can lead to compromise in the patient's heart's pumping power? The commonest cause is overexertion or fatigue, like uncontrolled hypertension, can cause overexertion for the heart, continuous overexertion, and that can lead to heart failure. Even aortic stenosis, if you've heard of it, that is narrowing of the opening of the arch of aorta, through which the heart has to pump out the blood to reach the entire body. And if this opening of the aorta is stenosed, that is, it is constricted, heart has to push the blood out through this narrowed opening of the aorta every time it tries to pump out the blood. That is, even at rest, 72 times per minute. And therefore, this can cause excessive fatigue and heart can go into situation called congestive heart failure. But even some acute situations can lead to development of congestive heart failure, like acute myocardial infarction that we've been talking about. Infarction is death of the tissue. So if a big chunk of the wall is dead, it will compromise the force of contraction and the patient will land into heart failure. What happens if we do not take care of these patients? If we do not address this problem of the patient can land into sudden severe reduction in ejection fraction and the presenting symptoms associated with it, which is referred to as acute left ventricular failure. As a chronic outcome of this congestive heart failure, the heart goes on undergoing hypertrophy, and this hypertrophied heart can create problems in conduction of impulses, and so these patients may develop arrhythmias or dysrhythmias. Let's go back to understanding the CHF pathophysiology. So congestive heart failure is reduced force of contraction of the heart, and therefore there is reduction in ejection fraction, which is the parameter used, as we discussed, to assess the severity of congestive heart failure. By the way, why do we call it congestive heart failure? Where is this congestion in these patients? Very often the answer we get is in the heart. No, congestion is not in the heart. If you heard about traffic congestion, if there is some problem somewhere in the road, traffic builds up in the road behind that point, in the direction going towards that point. And therefore, we would say there is traffic congestion because it cannot pass ahead through that problematic point. Similarly, if the heart cannot pump out effectively, if it cannot throw out the blood which has come back to it, it cannot accept more blood coming back to it. And therefore, there would be congestion in the area from which blood is coming back to the heart. For example, if right ventricle does not pump out effectively, where would the congestion be? Right side of the heart is receiving blood from the systemic circulation, and therefore there would be systemic congestion, which could manifest as venous engorgement, because this systemic blood is not able to pour into the myocardium. Similarly, if there was left-sided failure, if left ventricles were not pumping out effectively, where would the congestion be? Where is it that the blood is coming back to the heart, to the left side of the heart from? It is from the lungs. And therefore, left ventricular failure would be associated with pulmonary congestion, backlog created in the lungs, referred to as pulmonary congestion. And what would this present as? If there is too much accumulation of fluid in the lungs, if there is too much pulmonary congestion, there is respiratory distress because it hampers gaseous exchange. Alveoli should be able to receive air. Instead of that, if there is fluid in the alveoli, gaseous exchange is hampered, patient starts going to labored breathing, and this respiratory distress is the presenting symptom of acute failure, that is acute left ventricular failure. So which do you understand is more dangerous, right-sided or left? Obviously left, because it immediately compromises. Excessive left-sided failure immediately compromises the gaseous exchange, and therefore patient would land into ICU requiring intensive treatment. Of course, we would be seeing drugs which help us to avoid this acute episode. Coming back to the basic pathophysiology, that is reduced ejection fraction, the immediate consequence of that is reduced cardiac output. And if you have studied the physiology of blood pressure, you would know that the moment cardiac output goes down, compensatory mechanisms are activated in the body. And what are these compensatory mechanisms? What can compensate or correct the situation where cardiac output has gone down and therefore blood pressure has gone down? The two mechanisms which can help the body come out of this situation is sympathetic system and Renin-Angiotensin-Aldosterone system, both of which can raise the blood pressure through various mechanisms, as you will see subsequently. So, the moment there is drop in ejection fraction, cardiac output drops, which will result in drop in blood pressure. This compensatory mechanism is activated. And this will help us to understand the pathophysiology of congestive heart failure and what goes on if we do not take care in time. So as discussed earlier, basic problem is myocardial inefficiency, inadequacy of pumping power, and therefore cardiac output drops. And this triggers activation of compensatory mechanism, which is sympathetic and Renin-Angiotensin-Aldosterone system. What does this sympathetic system do? If it is activated, it will cause release of adrenaline from adrenal medulla and norepinephrine from the postganglionic nerve endings. And both of them together will stimulate the myocardium further. That means they will possibly increase the force of contraction, but they also increase the heart rate. And here we have a heart which is not able to do its job even 72 times per minute. And if it is made to run because of sympathetic overactivity, it will collapse. So this sympathetic overactivity is trying to help out this body by stimulating the myocardium, both rate and force of contraction. It also tries to constrict the blood vessels, arterioles as well as veins. And if arterioles are constricted, the resistance against which the heart has to pump, that gets increased. That means this mechanism is increasing the cardiac workload. And we have a heart which cannot handle the normal, even resting workload. Okay. Similarly, if the veins are constricted, what is the consequence? If the veins are constricted, venous return is increased. And again, we are increasing the workload on the heart. Even more importantly, if the earlier venous return has not been pumped out and there is greater venous return, it goes on increasing the end diastolic volume, which is also bad for the heart because it requires more and more energy if the chamber is bigger and bigger. What does this renin-angiotensin system do? Renin is a circulating hormone which is secreted from the juxtaglomerular cells in the kidneys, and that will cause ultimately formation of angiotensin 2. There are steps in between. Here we are concerned with formation of angiotensin 2. And this angiotensin 2 is again a very powerful vasoconstrictor. It will constrict both arterioles and veins and thereby increase the resistance, which is also referred to as afterload, and increase the venous return, which is referred to as preload. Another mechanism by which angiotensin 2 can increase the preload is cause release of aldosterone, which causes conservation of sodium in water, thus increasing blood volume to a certain extent. And this can lead to further increase in the preload. So this compensatory mechanism, which is supposed to help out this individual because the cardiac output has gone down, because the blood pressure is going down, the only avenues for doing it are actually not conducive to this heart which has become weak. They're in fact making the condition even worse. The heart which cannot beat effectively at 72 times per minute is made to beat faster with more load piled up on its head. Both afterload is increased and preload is increased. And thus, the same compensatory mechanism which is supposed to relieve this congestive heart failure symptoms makes things even worse. Another important contribution to worsening of the condition by renin-angiotensin-aldosterone system, particularly the aldosterone component of it, is causing remodeling. Remodeling is causing the cardiac hypertrophy, and the hypertrophy is not muscular hypertrophy. There is a quantum of collagen tissue which is added, which is non-elastic. So this bulkier heart becomes even more ineffective, has even more compromised force of contraction. And thus, this compensatory mechanism itself is responsible for worsening of the condition for this heart. Let us stop here and think for a while, how can we help this heart? And that's where we will come back in the next session. How can we use drugs to help this failing heart?